Hello, my name is Michelle Morand. I am a precision cancer medicine educator and advocate, have been helping cancer patients for over 14 years navigate their cancer diagnosis and just make sure they're always getting the most thorough and beneficial treatments. And I've not been doing that by myself by any means. I've been actually in support of this fellow here, Alexander Rolland, who we call the cancer guy, who has dedicated his life to the study of cancer and in the last 15 plus years, the field of precision cancer medicine. So Alex is here with a presentation that he's prepared about advanced colorectal cancers and a very beneficial new therapeutic combination that is really a game changer for all colorectal cancer patients. So Alex, tell us all about this.
Yeah, so one of the biggest questions I get asked a lot, and one of the biggest questions most doctors get asked a lot these days is, can I get immune therapy?
Okay.
And when it comes to colorectal cancers, it's a very specific percentage of patients that have the traditional markers for immune therapy. But what's really changed lately with immune therapy is synergistic combinations. And synergistic combinations target different pathways that are involved in, let's say, preventing standard immune therapy drugs from working. So, we're getting a really good picture of how the immune system works in regards to cancer. We still have a bunch of pathways to resolve, but we're figuring it out. And so I'd like to talk about a perfect case example of this.
Okay.
So colon cancers have many different biomarkers. One of the most common ones is in the RAS, and it can be an NRAS or a KRAS. Typically, it's KRAS.
Okay.
Um, these are primary mutations that occur early on in the transformation of a colon cell from a normal cell to a tumor cell.
Okay.
RAS is one of the big transforming mutations that occurs in many colorectal cancers, and it reduces the benefits of the standard chemotherapy treatments, as
Okay.
well as creating a more aggressive disease.
Mm.
So, for example, if you have these negative biomarkers, then you'll have a reduced response to standard chemo treatments, standard care treatments, than if you don't have a RAS mutation. Uh,
Okay.
Probably about 40 to 50% of patients that we see with colorectal cancer have a RAS mutation. And, as I said, it results in reduced responses to any treatments. So what we're about to share right now is a new treatment protocol. It's going to be a game changer for all colorectal cancer patients, regardless of the biomarkers.
Okay. That's exciting.
Yeah. So immune therapy using programmed Death-1 PD-1 inhibitors has changed the treatment landscape for many cancers. We've seen some incredible results for PD-1 inhibitors. Programmed Death-1 is just one of the pathways that tumor cells will use to manipulate the immune system and prevent it from attacking them. We also have CTLA-4, and there's probably another 12 or 14 different pathways that we're in the process of developing drugs for. But right now, PD-1 is one of the fundamental pathways. Now, PD-1 inhibitors don't work on everyone. Some patients, they don't work on. Other patients, they work really well. But in general, as a single agent, PD-1 inhibitor-based immune therapy has only been shown to benefit a very small percentage of colorectal cancers.
Mm.
And those are ones that have specific markers. And those markers are typically high tumor mutation burden or microsatellite instability, typically. And, that's the key one, microsatellite instability, also mismatched repair. But for most patients, standard chemotherapy is all that's offered. So there has been a development internationally. This development has been very slow in coming to Canada. Very disappointing that it's been such a slow process in Canadian doctors uptaking this. But internationally, it's a big thing. In fact, I spoke with a patient just yesterday whose doctor had him on this protocol from India.
Mm.
So a standard care for colorectal cancers typically involves surgery, radiation therapy, and then the chemotherapy combinations of FOLFOX followed by FOLFIRI. So these are specific combinations of chemotherapy drugs. Typically, it's done with FOLFOX and then FOLFIRI. For most patients, the combination of FOLFOX and then going on to FOLFIRI results in about a 25, 26 month overall survival for patients with RAS mutations. Now, if you don't have a RAS mutation, then typically the average survival with these protocols is about 37 to 40 months for RAS non-mutated. The Tribe 1 protocol, which first came out in 2015, combined FOLFOX and FOLFIRI, and then also added Avastin, bevacizumab, and they called it FOLFOXIRI-Bev. And what they did is they found that if you use, rather than using these two protocols sequentially, if you combine them together at a slightly lower dose of the individual drugs, and then add Avastin, you get a much better response, and particularly in cases that had bad molecular markers like PIK3CA or even RAS. And so that on average has increased that average survival from 25, 26 months to at least 30 and sometimes higher. So that was called the Tribe 1 study. And then what happened was a group of doctors said, well, why don't we see if we can add a PD-1 inhibitor to this Tribe protocol, and we'll call it the ATEZOTRIBE. Atezolizumab is the name of the immune therapy drug that they used. So they've tested a few different settings, and they started in advanced. But what has been really unique about this approach is that there's a unique synergy that occurs when you combine certain drugs such as chemotherapy and immune therapy. And that synergy is not achieved from those drugs when they're used sequentially. So in the ATEZOTRIBE trial, they showed a definite numeric benefit in overall survival with the addition of atezolizumab to the first line FOLFOXIRI and bevacizumab. So in this trial, it was for patients with unresectable, that means they couldn't get surgery, metastatic colorectal cancer, and they received either atezolizumab plus FOLFOXIRI-Bev or just FOLFOXIRI-Bev. In this trial, the median overall survival was 33.0 months in the atezolizumab group versus 27.2 months in the control. So 27.2 months, somewhat slightly lower than what we would expect for FOLFOXIRI-Bev, but there's some variation in that. Importantly, when they looked at subcategories of patients, they found that the median overall survival was not reached for the high tumor mutation burden patients and mismatch repair patients receiving atezolizumab versus 29.2 months in the FOLFOXIRI-Bev group. So that's quite substantial. And so tumor mutation burden high occurs when a patient has more than 10 DNA mutations per million base pairs of DNA on a tumor DNA sequencing test. And this really outlines the importance of getting tumor DNA sequencing, getting a proper tumor DNA sequencing test that looks at a lot more than just RAS. You want to look at mismatch repair deficiency. You want to look at tumor mutation burden high. You want to know all of these different features so you can optimize them.
And that high tumor mutation burden, like the larger the panel you have, the more mutations are going to be identified. So if your hospital is just testing for a handful, as they often do with colorectal cancers, they're not even testing for enough to really see if you have this.
No, typically they test for RAS because if you don't have a RAS mutation, then you could go on a class of drugs called EGFR monoclonal antibodies, cetuximab and adalimumab. These drugs will significantly add time to patients. However, if you have a RAS mutation, they just don't work. And so that's why they typically do this basic panel of RAS mutations, because they want to see if you can get these EGFR inhibitors or not. So additionally, they did something called an immunoscore. An immunoscore is a fairly new thing. What the immunoscore does is it looks at a variety of different genes, looks at their expression, and it tells you whether you have a immune hot tumor, in other words, a tumor that has a good chance of responding to PD-1 inhibitors, or immune dead tumor, which means you probably won't get a response to single agent immune therapy. But in this particular study, when they looked at patients with the immunoscore high and still proficient mismatch repair, we found that the overall survival was 41.7 months versus just the 29.6 months of the atezolizumab. So quite a substantial difference. Now
Mm-hmm.
let's look at, of course, I don't like to go with median overall survivals. As you know, overall survival and progression-free survival are medians. And what they refer to is 50% of the patients in the trial. So for overall survival, the median overall survival refers to when 50% of the patients in a clinical trial died from the disease. Now we did a statistics, how to understand oncology statistics video. So I do suggest people watch that. It's really important to be able to understand the data. And we do cover curves, which is a really important thing. I'm going to go with the curves here. So what the curves are, you'll see these little dots here and on the lines, and you'll see each one of those dots is a patient. And this is referring to the overall survival of this trial. And this is a 4-year update that they did. And so you can see the standard care was blue. And then if we look at the general intention or the general population right here, and you can see the difference right here. So the median overall survival is 50%. So if you go right across like this, you'll see it's right there, and that is just down there.
27-ish, as it said.
Yeah, so it's slightly higher here, but you don't get a really good indication because it only shows a couple months difference between these two, right?
Uh-huh.
You know, at the 50% mark, there's only a couple months difference. However, when you go further down the line, you'll see this drops off and this stays a little high. So, you know, at 50 months,
Almost.
40% of the patients
Mm-hmm.
on the atezolizumab combo are still alive.
Mm-hmm.
And, you know, that's quite impressive.
Yeah, versus like 25 or so maybe for the other.
Exactly.
Rolland.
Yes.
Yeah.
Yeah. And so this is for the tumor mutation burden high, as you can see right here. And you can see that, you know, at 60 months, 40% there. And then this is with the immunoscore.
Okay.
So they have immunoscore high and immunoscore low. But you can see right here, this is immunoscore high.
Mm-hmm.
And you can see, look at this, you know, at 50 months, almost 70% of the patients are still alive.
And so just to be clear, the immunoscore essentially is the same thing as showing high tumor mutation burden or
No, it's different. High tumor mutation burden is an indication of whether you're going to respond to immune therapy,
okay.
because you have so many mutations that the tumors look really different, and it's easier for the immune system to recognize them.
Okay.
Now, having high tumor mutation burden also comes along with potential problems. Basically, it means that you have a lot of different potential driving mutations.
Mhm.
And you know, no one mutation is going to have a huge impact on the tumor because there's many different drivers. And so they're actually become, so, you know, while we like to see tumor mutation burden high, because of it shows benefits of immune therapy, it can also create problems down the road, you know, subpopulations.
Sure.
This immunoscore is basically just looking at genes involved with the immune system. And it's something that is somewhat random. So
Hmm.
in other words, you either have a high immunoscore or you don't. It's based on expression of certain genes that
Okay.
are involved in responding to the immune therapy. And so this is not something you would have a good indication of just by looking at or just by doing pathology.
Hmm.
You know, immunoscore high, you're not going to be able to tell the difference between an immunoscore high and immunoscore low patient typically just by looking at their tumor. You have to test it with this score. So,
Okay, and this is an RNA expression type
yeah,
test.
RNA expression test, yeah.
All right, got it. As opposed to tumor folks, tumor DNA.
Yes.
Yeah, here, let me, I expanded everything here. Let me make it a little bit more
So
manageable.
this is the study. So if you want to look up the study,
All
we've
right,
been watching this for quite
less
some time.
blurry
Yeah.
charts there too, less blurry graphs.
Exactly.
Yeah.
So that's it.
All right. Okay. So to summarize, the combination with the immune therapy, as we saw in that last graph specifically, for certain subsets of the people. So even if you have the RAS or something like that, you're still going to get a greater benefit out of this combination than out of the standard FOLFOXIRI-Bev or whatever they're now doing it as the standard. So that's good. But if you also have that high immunoscore,
Yeah.
then you at 70% still at
50
50 months.
months. Yeah, that's amazing.
That's pretty awesome. So definitely. So if you want some people on your side figuring out if that's you, if you are a fit for these, Alex and his team will help you answer that question, and then they will advocate with your oncologist, your cancer agency, to help you get access to the care that you need. So you don't have to figure this all out by yourself. But if you do have colorectal cancer and you do want to make sure you're on the best possible treatment, I do recommend that you book in a consultation with Alex, explore all your treatment options, and then get their help. I also have a precision cancer medicine educator and advocacy course that's free to join. We have a couple of times a week a drop-in. You can pop in and ask me questions as things unfold. And once a month, Alex hops on for a drop-in Zoom. All that information is shared with you via email once you register for the course. So follow that link, sign up, and join us as and when you need. And subscribe to the YouTube channel, because that way you will always be notified when new videos are dropping. And we're doing that at least once a week, if not a number of times a week, on all different topics. And lastly, if there's a specific topic that you are very interested in, or one of your support groups that you're engaged in is continuing to kind of struggle with a problem or ask a question, just let me know, because we'd be happy to deep dive into that for you and make a video to help clarify that for you.
Mhm.
All right. Well, thanks very
Okay.
much, Alex. I appreciate you putting this together for everyone.